So without further delay, now I invite Professor Dr. Garg. I think we all know him, and Tapas has already introduced Dr. Garg, so I will not take further time on the introduction because otherwise it will take another few minutes. He's going to speak on a very, very important topic, which we all love to talk on, a p-value, or rather the interpreting research beyond statistical significance. So over to you, Dr. Garg.
Thank you, Dr. Nasa, and thank you, Dr. Sahu, for this opportunity. And Dr. Braham has laid a good foundation on understanding the statistical or the research aspect. So usually when I was young, when we talk about research, I was just thinking that number matters. So if something is big, it is important. Something is not so big, it was not so important. But if, as we just understood for the guidelines and other discussion which was going on, uh, one basic thing which my teachers have taught me, even for patient management, that we have to teach the patient, not the numbers. Probably the same line would be appropriate for the research outcome also. We have to interpret the research based on the holistic method, clinical involvement, and the numbers. It is just not the numbers interpreted and conclusion to be made. And I think this is statement when we say when numbers mislead, interpreting research beyond statistical significance. I think that corollary works well for our patients also. So next around 20-25 minutes or so, we will understand that is p-value so-called as sacrosanct number, which all researchers were looking for, and any value less than 0.05, it was eureka. But then it has something more than that, and we need to understand those aspects. And those are not so difficult or something advanced statistics to understand. They are simple things which just comes under the purview of, you can say, the understanding. As Dr. Braham mentioned, that when we say the guidelines has three pillars. It's just not the evidence, but it also needs to be under the purview of its implication on a resource with funding, with cost, with experience, and so many things. Similarly, we need to understand and interpret those data accordingly. Now, if we do not lead to appropriate interpretation, it will lead to the adoption of ineffective or harmful interventions. It can overestimate benefits, underestimate harms. It can influence guidelines, funding, and policies incorrectly. So this means we just not have to think 0.05 p-value, but we have to think much beyond that so that we can interpret those numbers more appropriately. Statistical significance does not automatically imply clinical importance, biological plausibility of whatever hypothesis you are looked for, or the truth in the research question by answering by these numbers of p-values. Now, let's understand what exactly p is. P basically is the probability of observing data as extreme, maybe either side, the current data, assuming the null hypothesis is true. Or maybe if you in a more simple language, that when we say p is less than 0.05, it just means that there is less than 5% probability that the observed difference occurred by chance alone if there is a truly no effect. And that is what the p-value means. It does not signify that something is better than other, something is inferior than other, something is clinically more benefit than other, and we cannot conclude just based on these values. So just summarize that the p less than 0.05 does not mean that the result is clinically important. It does not mean that hypothesis is true with 95% probability. It does not measure the magnitude of effect, and it does not guarantee the reproducibility. Now, when we are concluding our RCT or a study based on this, you understand that majority of time our conclusion will just rotate around these four statements which has mentioned, but none of these statements are concluding from the p-values. Hence, we should be more cautious to look for something more than the p-value itself, so that we can look for that what our research is saying beyond these numbers. Now, let me take you through some examples. Like if you think of, say, something is clinically important, but sometimes statistically is not significant, the researchers feel that is a negative study. Now, let's see this study, a pilot study of a new vasopressor in a refractory septic shock. And the mortality reduction is, say, from control of 60% to intervention of 45%, the absolute reduction of 15% in a sample size of 40, and we get a p-value when we compare these outcome parameters to be 0.08. What are we looking for? Now, what we understand is the p-value is 0.08. Should we say that the both groups are comparable? When we're talking about a hard outcome like mortality of control 60 versus intervention 40% with absolute reduction of 15%. Now, this type of large clinical meaningful effect may be significant for a study, though they have not been statistically significant. Maybe the sample size is small for the patients. It may be underpowered sample. But again, this study is giving a hint that probably the intervention is having some clinical significance. So we need to have some appropriate powered study to confirm this. So we cannot say this is a negative study with no effect, and this new vasopressor is of no useful effect is septic shock. And this conclusion may not be appropriate, though it's a pilot study, small study. But again, it is giving a hint that yes, it may be useful. Statistically, we are not able to get a p-value of 0.05, but probably if you get an appropriate sample, probably it will give some value. So the lack of statistical significance, that is p-value 0.05, less than 0.05, does not prove lack of effect. So try to get your data, understand well that yes, there is a difference, and that difference is not leading to statistical significance. There should be some problem with the methodology aspect, and here probably it may be the sample size, and hence we should not just negate the study and leave it that this vasopressor is bad, it's not useful, and I think we should dump it. So be very careful in interpreting clinically important but not statistically significant data coming out from the study. Now, similarly, when we interpret this, the studies, we also need to look for the effect size. Now, there would be some difference which would be coming in the control versus the intervention group, but how big is the effect? Because this is important. When we say the effect, it matters because it will tell us the magnitude depending upon what your hypothesis was, the benefit or the harm, and will help us to take clinical judgment with clinical relevance. And when we want to see this effect size, we have to use certain statistical tools for it. And these are certain tools which you can use for whatever the p-value is. But if you add on to them, you will try to get some more value, more understanding from the same numbers. And these common measures which we use for the effect size may be the form of mean difference sometimes, standardized mean difference, relative risk, odd ratios, absolute risk reduction, number needed to treat or number needed to harm. So these are the additional numbers we should look for when we are looking for the numbers or the data that we are getting from our data collection and then doing the statistical analysis. Let's see these examples once again. Now, we want to look for an intervention on the outcome of a patient from a renal disease. And we found that intervention, the data, the relative risk is 0.80. This means, if you say just want to explain it in a simple language, this means that the treatment reduces the risk by this intervention by 20% relative to the control. If the baseline risk in this study was 2%, that is the control, the event rate in the control group, then what does it mean? Now, if you just see superficially, if you see the 20% reduction, it's a huge reduction. And I think this intervention is very useful, impressive benefit. But wait, let's see further on. Now, when we say 80%, if we just try to interpret little more in its understanding, this means that if 100% are untreated, 2 out of 100 will have the event. And that is what the baseline control event at 2%. And with treatment, the risk becomes 1.6% because we have mentioned the R of 0.8 and the event rate is 2%. So the treated risk would be 1.6%. Now let's see. Initially, we said that 20% is the reduction in the relative risk. But now we say that the difference would be 2% versus 1.6% here. Now, this difference labeled as absolute risk reduction of a patient where we say the control event rate was 2% baseline risk. And if we treat the patient, the risk becomes 1.6%. This means the absolute risk reduction is approximately 0.4%. This means only 4 fewer events will happen when we treat 1,000 patients. And we were just discussing in the previous session that the cost, the infrastructure, the manpower, whatever the intervention was, maybe it was intervention with dialysis, means to reduce that event, 4 events, we have to treat 1,000 patients before we get it. Do you really think that this intervention is really very useful to us? This means we have to understand those values very well. And if we translate it further, and if we add on some other numbers, like number needed to treat, which is basically 1 by the absolute risk reduction, where 1 and ARR is 0.4, as we have just mentioned. So this means the NNT will be 250. Simply, it means that 250 patients must be treated to prevent 1 event. Now try to analyze your intervention. Do you think that your intervention has to be given to 250 patients to prevent 1 event? It is infrastructurally viable, financially viable, in a very high output hospital where you have shortage of bed, the number of patients coming are huge. Do you think this intervention will be of some use? So probably the initial interpretation that 20% relative risk reduction, it reduces events by 20%, impressive benefit. But if you just analyze it, probably we need to understand the event is rare, only 2%, and even a 20% relative risk reduction, relative reduction will translate into a very small absolute benefit, and you have to treat 250 patients to prevent 1. This is how you need to understand your data, which you obtains. And same thing will be applicable when you prepare the guidelines, when you prepare the critical appraisal of a published paper, that whether that paper is suitable to your infrastructure. If you think that you may go ahead and treat 250 patients because the outcome, maybe that it's preventable outcome and the intervention is very small intervention, just say supplement of 1 tablet, it's allowed, it's okay. For example, the vaccination aspect. But if you think it's like a huge infrastructure load, for example, giving the dialysis, the CRT therapies or something else, it may not be viable. So this correct clinical interpretation, again, is very important for whatever data. So you have to think beyond the numbers, think beyond the p-values itself. So although the risk reduction appears large in this study, the absolute benefit is minimal with an NNT of 250. And this is when you publish your paper, you should also put the same understanding into your conclusion or discussion. This means that most patients receive no benefit, yet all are exposed to the cost, inconvenience, and that intervention is too invasive, it can have a potential harm. So the clinical decision must be guided by many other factors rather than having just comparison of some outcome parameters and comparing the p-values and those. Large relative risk reductions can hide very small absolute benefits when the baseline risk is low, that we have just discussed, and hence be very cautious. Let's think something other than this. Statistically significant result, but clinically modest and methodologic fragile outcome parameters. Let's see how this affects us. Let's the scenario where we are talking about the involvement of the early versus delayed initiation of RRT in patients with septic shock with acute kidney injury. Now, if you see the primary outcome in this trial, these are all hypothetical trials. Let's see if the primary outcome was 28-day mortality. And the mortality, the early RRT rates was 38%, delayed RRT was 42%, relative reduction risk was 0.90, the p-value was 0.04. So what do you think would be your interpretation for this? So probably, I think if somebody feels they can just in the chat also. Probably, if you just see this data, it will look that early RRT significantly reduced mortality because p-value is 0.05 here, and it is having a reduction of some percentage that mentioned in this data. But if you better understand it, again, the earlier example, if I just continue into this also, here the absolute risk reduction is just 4%, and the NNT is 25. If we calculate some other statistical tools and try to find out, say, for example, confidence interval, and if it comes out to be the confidence interval for the RR for 0.78 to 1.04, when they're crossing a line of no zone, this means it includes no effect. And there could be many things which could have been involved into this phenomena where you do not know whether it's high crossover rate or delayed patients who will never require IRT. So this interpretation probably will mislead if we just look for the statistical aspect rather than the other aspects. So this means just p-value of 0.04, that statistically significant result, but clinically modest and methodologically fragile, because when you are looking for the method sections, the timings, the crossover, the previous dialysis and the subsequent dialysis, because these patients may be on a long-term dialysis. So whether it was in a previous shock or previous septic shock, or they have been started at which time intervals, these are all limitation of these studies. And when we label them as methodologically fragile, so based on these just p-values, you should not be starting changing your hospital protocols or guidelines to change something. Similarly, if you talk about the statistical significance without clinical advantage should also be important for you. For example, let's see this study. Now, when we talk about the CRT effluent flow, and if we just compare high versus low of the effluent CRT flow in as 35 mils per kg per hour versus 20 ml per kg per hour, and we look for the ICU mortality with a difference of 1.5% and p-value of 0.01. Now, this statistical significance, if this sample would be large, this will be represented into a p-value, because we have earlier mentioned the definition of p-value, that is the probability by chance. So there probably would be, because of a large sample size, this statistical significance can come. And there may not be a meaningful clinical benefit, but when we are trying to add it with a mortality of difference of 1.5% of high versus low effluent flow, we also need to remember, though we are having a mortality difference of 1.5%, but simultaneously, there would be additional other clinical changes, which may be electrolyte loss, hypophosphatemia, increased cost, financial burden, more patient hospital admissions, and other aspects. So this has to be balanced. The statistical benefit of 1.5% with significant p-value may not be having a meaningful clinical benefit if you try to include other concerns which are associated with this intervention. So this means the statistical significance without clinical advantage should not be a primary factor for change of clinical practice. Similarly, if you talk about the diagnostic accuracy, similarly, if the statistical significance is there in the diagnostic accuracy, this does not mean that that test, that marker may be of clinical utility. Let's see this example once again. For example, we are using a lot of biomarkers now for predicting something. And for example, say Angel for biomarker guided AKI prediction. And when we say prediction, we usually have statistical tool. We talk about the area under the curve, and based on this, we get certain value and we put it here. Now, suppose this comes out to be the biomarker prediction for AKI application at 0.72 with P of less than 0.001. This appears that it is highly significant, must be useful. But the AOC, though we say it's acceptable limit, but the area under curve of 0.72 means it's only a moderate discrimination. This means it's 72% chance of correct ranking that this biomarker of angiotensin-2 is actually predicting the AKI. And if you're predicting it, this means we'll be looking for more interventions. Once we predict, we cannot take the patient. We'll be doing a lot of intervention. So do you think this moderate discrimination of this biomarker based on this value, p-value and area under curve is sufficient for us? No proven impact on patient-centered outcomes here. Maybe the mortality, the dialysis dependence. So if this marker associated with some hard outcomes or some patient-centered outcomes, which we are looking for. And this is, if you see the last couple of years, the researchers has been talking about patient-centered outcomes, wherein we are looking for values which actually translates into some clinical outcomes. So this means the statistical significance in diagnostic accuracy does not equal to clinical utility. Similarly, in continuity to what I just mentioned, we need to look for the surrogate outcomes also. When we say the surrogate endpoints, now these surrogate endpoints probably in the initial researches were for the ease of the researchers to measure them appropriately, more comfortably in short period of time. And they will be the inflammatory markers, the biological markers, the various blood tests, the urine tests, and other things which were coming up. Now, if a drug significantly lowers inflammatory markers and you get a p-value of 0.001, but patient does not show improvement in survival or functional outcomes, do you think is this surrogate marker, which is statistically significant, is of any help to us? So we are getting some significant statistics point of view with p-value, but if we are translating into the patient survival or patient-centered outcomes being affected by this lower inflammatory marker, probably we are not getting any good outcome from this study based on the surrogate endpoint. So this means the statistically significant in surrogate outcomes does not guarantee patient important benefit. Hence, when you interpret these studies, be cautious that these surrogate markers, inflammatory markers, or whatever the soft markers or soft outcome parameters, they may not be translated into real patient-centered outcomes, and hence interpretation or guidelines and policy making changes, you should be very cautious. The other important aspect, we'll talk about the numbers and p-values. Improving a number is not equivalent to improving the patient. Now, this is again important aspect. For example, let's talk about this loop diuretics in oliguric AKI. There's an observational study where the furosemide is associated with improved urine output. Urine output increased significantly. P-value is less than 0.001. Does this mean that this loop diuretic is really useful by increasing the urine output? But there was no difference in the mortality of renal. So this means even if the number or the primary outcome measure, probably if you have put it as urine output, may have improved, it was statistically significant from the p-value point of view, which is, you can say, highly significant as less than 0.001, but it is not translating into any patient-related beneficial effect. The increased urine output in a patient of oliguric AKI is not equivalent to renal recovery, is not equivalent to mortality, as we have seen into our clinical practice also. So this means, though the surrogate endpoint, which was urine output here, has improved, it had a statistical significance, but the hard outcomes like mortality, the renal function, or change from AKI to CKI has unchanged. So this means improving a number, specifically the surrogate number, is not equivalent to improving the patient. Hence, understand the numbers well and try to understand how it affects. Let's see other numbers, issues also. Small trials showing no significance, but large clinical signal. What should we do? We said in the beginning that if there is a large study, the p-value may be exaggerated, it becomes exaggerated, and you can get a significant p-value. If the sample size is small, the p-value may not be so significant. But let's understand more significance out of it. For example, if you see this study, pilot RCT of early vasopressors with conservative fluid in septic AKI, the dialysis requirement, standard care 48%, conservative group 30%, absolute reduction 18%, p-value not significant, 0.09. How should we interpret? Now, this may be a small study. If you see the clinical significance, it may be of importance to us. 48% or 30%. And this less significance from p-value point of view, maybe because they're underpowered, but it appears that the early vasopressor with conservative fluid probably was useful to us. It has a promising effect. And definitely if we have the confidence interval and if it centers around the patient outcome, then definitely we can say that though this is underpowered, we are not very sure about it, but this becomes a hypothesis generator study, or this needs a larger study to confirm it. So this means that no significance of p-value does not mean no effect. So you cannot say that this does not have any effect and hence the early vasopressor but conservative of no use. Such results justify that we need to have a well-planned, robust, large trials before we say that this is not useful. Now let's see, when I just introduced the word confidence interval. So when we see the confidence interval, it also gives certain value. For example, if we say the mean time to renal recovery was reduced by 1 day in this study, mean difference was minus 1 day here. If you put it into a 95% confidence interval, if it is from -5 to +3 and p-value was 0.05. Now, when we understand, yes, we agree that renal recovery of less 1 day probably appears to be good for us. But when we see the data, apart from the p-value, it ranges from -5 to +3. This means the true effect of the renal recovery, mean time to renal recovery, can be a substantial benefit, or it could be no effect or no harm, because it is ranging from -5 to +3. So this remains an inconclusive study. Even if your mean difference may be of clinical significance, clinical advantage to you, but if you interpret your data more elaborately based on confidence interval, you say the result is inconclusive. So this means confidence intervals also needs to be considered when you are interpreting your p-values that will reveal uncertainty better than the p-values. When confidence interval shows, it shows the range of plausible true effects, the range you can see, the precision of the estimate, and the direction of clinical value. So confidence interval will convey both uncertainty and clinical plausibility of whatever intervention you are using it. Now coming to the last aspect when you talk of numbers, multiple testing, p-hacking. Now, usually when we say the critical care or the NephroCritical care or the patients suffering from kidney disease, they will have multiple parameters into this. Some may be coming for the first time AKI, somebody may be AKI on CKD, somebody have previous dialysis, some may not have dialysis, some may be post-transplant dialysis, some may be pre-transplant dialysis. Now, when we do a study, and it's a pragmatic study, and we have not decided the subgroups, if you try to a multiple subgroup analysis, and we do repeated testing until significance achieved, it becomes a major issue. We need to understand that when we do a study, we expect that the alpha of 0.05 is acceptable. And we accept it, because if we want an alpha of 0, this means we have to study the whole universe. That is practically not possible. So in general, we accept that the 5% or 0.05 alpha is acceptable. But that is for one outcome parameter based on which you have taken your sample size. If you do a multiple subgroup analysis, if you do a repeated testing, if you are doing multiple secondary outcome parameters, this 5% is further exponentially increased. And when you do it, even statistically, even if there is no concern, no values, there is no definite answer to it, if you test 20 times multiple analysis, multiple subgroup analysis, 20 secondary outcomes from a single study with a primary outcome, one is likely to be significant by chance. So this is nothing to relate to your intervention. It is by chance, because your alpha is increasing exponentially and that error is increasing. So always check pre-specified primary outcomes and trial registration. And only those primary outcomes which has been appropriately sampled based on those outcome parameters only, you need to interpret your data, not on the basis of subgroup analysis. Now let's say this one. Large ICU trial, no overall mortality difference between CRT and versus ischemic heart disease. They did a subgroup analysis, surgical versus non-surgical patients, and then say surgical patients show benefit because P was 0.03. Do you think it is okay? It was a large ICU trial. It was CRT versus IST. When they do it subgroup analysis, multiple subgroup testing, false positive is likely. Often biologically implausible and non-replicated. And if you repeat this study as a primary outcome, you may not get the same result because this is underpowered. So do not base your clinical management on unplanned subgroup significance because they are not sampled and you're increasing your alpha to an unacceptable phase, because usually we accept the type 1 error, the alpha of 0.05, and it gets inflated if you do a multiple analysis. The subgroup can be an hypothesis generator. If it is directionality, that probably in this group, something is different from the other group, this just gives a clue that, yes, this could be the primary outcome for a subsequent study, because 20 secondary outcomes, one will be positive. But yes, if you're seeing a very large data, multicentric data, you can do sometimes the multiplicity or subgroup analysis, but then you have to use certain corrections, which are called usually Benferioni corrections for those parameters, and then take them appropriately. But usually you should not, and they should be specified in your protocol submission, and your sample size should be appropriate for that. Similarly, the statistical power is lost. You have calculated based on primary outcome. That was your sample size. When you slice your cohort, do a subgroup analysis, your sample size drops, your confidence interval widens, your estimate becomes unstable, your effect size fluctuates. Hence, absolutely, you are not getting any meaningful conclusion by multiple testing because you are underpowered your comparisons that exaggerate the treatment effects or hide the real ones. So do not do a subgroup analysis because they are vulnerable to many aspects. Even the randomization. If you do a multiple subgroup analysis, the overall randomization was for the various parameters, but in subgroups, probably the randomization would not have been appropriate because you may not have done the sampling based on the various secondary outcome parameters so that you get equal distribution for various patient population equally in those subgroups. And hence, this random imbalances in the baseline characteristics in the study parameters will also affect the outcomes. So the randomization is partially broken, and then you will have confounders, you have imbalances, you will have loss of internal validity. So this means a subgroup may look different simply because covariates became uneven after splitting, and that may be the reason that the p-value has appeared to be significant. It has appeared to be less than 0.05. All those things will ensure that this is not true, and hence you should be cautious. Subgroup analysis is not preferred because it multiplies false positives, reduces power, undermines randomization, invites overinterpretation. It is useful for exploration, not for definitive claims. Can be an hypothesis. It gives a clue for future studies. But sometimes we may accept subgroup analysis if they are pre-specified, limited number, very important with strong biological rationale, adjusted statistically for multiplicity, they are powered for interaction, and they are interpreted cautiously. In those situations, you can think of those multiple testing. Always remember that in research, the common answer significant does not mean true, non-significant does not mean no effect. So what you need to look for is that there's nothing called dichotomous thinking, that this nothing is called 0 and 100. So there will be a range. So this means the evidence exists on a continuum, not as yes or no categories. Avoid treating 0.0549 and 0.51 as fundamentally different truths because there will be spectrum. We have introduced a term confidence interval for you. So try to understand that the P of 0.04 is not sacrosanct. Less than this, more than this does not mean that this is better or this is worse. And hence, you should be cautious. So statistically, significance just means unlikely due to chance. Clinical means meaningful to patient care. And biological plausibility means fits the known mechanism. You are able to explain its beneficial effect. And that's why you can just make some conclusion based on your clinical experience with addition of the statistical significance that this may be used, this needs to be used, this must be used. The other important reason is when you do a study and look for the numbers, even if the number is giving you something very specific, think that whether this finding can be replicated. Now, this is important. We sometimes say the internal validity, use the term internal validity versus external validity. But in a simple language, try to understand that if I repeat this, will that statistical significant findings will be replicated approximately in the same number? If not, the reason could be small samples, flexible analysis, publication bias, and so many things. So be very clear that one significant study rarely establishes truth, and that's why we are looking for meta-analysis in which we try to analyze multiple studies and then try to find the truth for that particular dimensions. So to summarize, when you look for a paper or you read a paper for critical appraisal, just try to look beyond the paper. Examine the effect size, examine the confidence interval, and look at it is clinically important. Is the estimate precise? Are the outcome patient-centered? Because finally, we have to treat the patient, not the numbers. And also simultaneously look for, in the method section, sample size, the power, the randomization, the blinding, which we just use in the form of a quality of study. And whether missing data, attrition, loss to follow-up, and whether they have been incorporated into the study analysis or not, and check for the bias. So this means look beyond just the p-values. There are many other things that you need to look for before you accept the conclusion to be useful for your patient management. Before accepting a significant result, look for the absolute effect size. Look for the confidence interval, whether it's narrow, wide, or clinically meaningful. Look for the outcome which is relevant to your patient care. Look that the result is consistent with prior evidence. Look that it is likely to change your practice and is useful to you. So to summarize, p-values alone are not sufficient to judge the evidence. Statistical significance is not equivalent to clinical importance. Always interpret effect size, confidence intervals, and the other things that we have just discussed. Beware of multiple testing. Think that surrogate endpoints are really useful to patient outcome and selective reporting. And your clinical judgment is equally important. And any statistical reporting should be integrated with your clinical judgment, with the biology, with the patient relevance, with the infrastructure, with the finances to make some meaningful conclusion out of it. So thank you so much. Statistics are tool to inform judgment. They are not substitutes for thinking. And that is what we talk about, critical appraisal of a published paper. And that's what when a researcher makes a conclusion, probably sometimes he has to think multiple hours, multiple days to write a single statement of conclusion from multiple sources, though he has the ready-made data and p-value. Not everything that is statistically significant is clinically meaningful. So be cautious when you see a p-value. Thank you so much.
Thank you, Dr. Garg. I think it was a beautiful talking more nuances of the research. And these are the challenges which we always see while writing our own manuscript or sometime reading while as reviewer or sometime even as part of the journal. I have a couple of questions, and I think one is something which is very close to me because I see that often happening, especially in the conclusion of the study. So this question is from Amita Singh. The question is, in conclusion of the study, if the p-value is insignificant, will you conclude that is it something maybe or can be better, but statistically insignificant, or is it wrong? We should say it is comparable, equivalent, or alternative, or with fewer side effects. So
I
how
think
will
this
you
is
interpret a result? It's not interpretation, it's conclusion, but you will be writing in the conclusion. So it's different when you are writing a result versus when you are writing a conclusion.
right. I think this is important. One thing is data versus results. So there are two different things. Data is what you find, what your statistical tool SPSSR shows you, and you put those values. When you write results, you have to interpret something statistically point of view in the results section. But when you come for the conclusion, there are three important aspects I will put here, though there are many other things. One is the clinical significance. Second is the biological plausibility. And the third one is obviously the statistical values that you have achieved. Though when we talk about the evidence and guidelines, we also talk about the infrastructure, finances, the availability and other things which we have discussed in the previous session. So when you conclude, it is important for you to mention all those three aspects. So probably if you say, if you want to put in a broad spectrum, we say that the drug A appears to be better than drug B statistically, but it does not carry clinical significance, and its biological plausibility requires further trial, and you have to mention the reason for it. So the difference which is there in the statistical significance, you mentioned can describe it. So if you are reading the recent journals, the last but one paragraph of the conclusion, the authors are putting the whole confusion there. And those are called limitations and future directions. Yeah. Read those paragraphs, you will get the complete conclusion. They will say that we have found this. However, this may be because of small sample size. They may have something blinding issues. There would have been something lost to follow up. They need a larger trials. So this paragraph will make you understand that P of 0.05, maybe less than that, may not have the clinical significance. You may not change your clinical practice. But also remember, sometimes the directionality or the obvious benefit, we usually say, if it's a pilot study, it becomes something called hypothesis generating study or a future trial study. So they become a base for the future studies. So they can be taken further because the direction shows a benefit of drug A would be, and you can take it forward. So your conclusion will be based on this. But simultaneously, as Dr. Brahm mentioned and previously Dr. Prashant also mentioned, when we want to conclude that no further study required, there are certain meta-analysis tools where we use sensitivity analysis, we use tri-sequential analysis, and then we try to conclude that no more studies, we are confirmed that drug A is better. that be. So then we can conclude very clearly based on those parameters. But yes, not based on usually single-centric small RCTs, even if it is of good quality.
I think that tells a lot about reading a conclusion, and the paragraph above conclusion where the lot of limitations and strength make sense. The bigger I see the limitation, I really feel the people have really put hard on their work and they have reflected on their work beautifully, rather than saying that number of limitations are more, that's a bad study. No, that's the real good reflection people have done. In fact, the number of limitations are very small. It means people have just been hiding certain things and it's not been reflecting over there. So read those limitations, they are very, very important. There is another question for you, Dr. Garg. What is your view about majority of the studies which are trying to see the effect of intervention on hard outcomes? Again, very opposite to one which you presented, that we sometimes just are bothered about the hard outcomes outcomes like mortality and not other patient-centric outcomes.
I think if you see the studies, I remember if you see the studies around 15, 20 years back, and if you see the patient population be included, we were talking about PICOT. You say, if you talk about ICU, patient will say hypotensive patients were excluded, diabetic patients were excluded, less than 18 were excluded, patient with previous history of CKD were excluded. But then my patients, 90% are all like this only. So if we exclude all patients, then probably what I'm going to treat, should I change my clinical practice? So when you say the intervention, there's something called pragmatic studies. So they are real-time studies. So you have to do a study which actually is almost near and dear to the way you're managing your patient. So we call as pragmatic studies. Now, this is one aspect. So if I get, say, 30% of my patients are diabetic, 30 patients who comes into my ICUs are having AKI on CKD background. So my study should be based on this. So don't try to exclude or no patients just because of the sake of research, which was one of the issues 15, 20 years back, a lot of very strict inclusion-exclusion criteria. This is one. Second thing is, all studies are good. When you interpret them, look for what actually you're looking for. For example, say my ICU is a very high output ICU. I want that even 1 day reduction in the ICU care, I will be able to take care of not 10 patients, but 20 patients, because 25 patients are coming to my ICU. Now, my primary research question, Dr. Braham mentioned about PICOT. Try to think that what my ICU wants. I want that I should admit 20 patients in a day. If I can reduce 1 day in the ICU, I will be okay, because I can increase from 10 to 20. This is my clinical problem I am facing. Here I will use a soft outcome, surrogate outcome. Even if I can reduce a ICU stay from 4 to 3 days, I am happy, because I will be able to take care of more patients. But if my outcome is, if I say that my patient is having a mortality of 60%, and Dr. Prashant's ICU is having a mortality of 30%, Dr. Sahu's ICU is having a mortality of 10%, now I have to think of, my patient profile is same. Dr. Sahu's, Dr. Nasa's, and Dr. Garg's ICU is same. But why my mortality is different? I have to look for. This means some problem is there with my patient profile or my intervention. Now here, the intervention will depend on mortality, because now my outcome is that my mortality rate is much higher than the contemporary ICUs. So I have to look for some intervention. So I'll ask Dr. Prashant, are you using something? Your patient profile is something. So now here, my surrogate outcome will be mortality. So this means all outcomes are good. We say nowadays patient outcomes. People have started using, especially in ICUs, something called composite outcomes. Even the single outcome is not good. A patient who has a morbidity, if he remains in the ICU for 30 days and he remains CKD4 after admitting with sepsis in ICU, think about the long term. He came with normal kidney functions and is getting out of ICU with CKD4 and getting dialysis every second day. So we have to seek so many factors. So people are looking for now composite outcome parameters. So based on your clinical problem, surrogate outcomes are good, composite outcomes are good, soft outcomes or surrogate outcomes are acceptable, and hard outcomes on mortality. This depends upon the clinical problem. It depends on the intervention. But if we see the recent things, we are shifting from biomarkers or those things which are well established. Those things are being shifted to the hard outcomes, patient-centered outcomes. Now, this is a hierarchy of study. when a research starts, try to understand this thing. When something new comes, we do a case report. We think it's good. This is higher. Then we go to the case series. And then we think that something is being generated. This appears in 10 patients that this technique is better. So they are labeled as hypothesis generator. And then we do something called a pilot study, or we do a retrospective analysis, or just an observation study. And then we do a RCT, then we do a meta-analysis, and then we reach the guidelines. So this is hierarchy. Probably same hierarchy can be used for the outcome parameters. When you have something new, you find that, yes, I'm looking for ultrasound evaluation of, say, I want to look for the EAV parameters for the analysis of fluid status, which is not so well recorded. Probably I will use some soft markers, fluid requirement in 1 in second, right? But when I have something, the soft outcome is confirmed, I will go to the next step. Is it really benefiting the patient? Yes, it is benefiting the patient. The ICU recovery or ICU stay is decreasing from 5 to 4 days. Length on the mechanical ventilator is decreasing from 48 hours to 24 hours. So this is definitely beneficial. Now, once this data is clear, I will go to the next. Is decreasing the length of ICU stay from 5 to 4? Is length of mechanical ventilation from 48 hours to 24 hours is really translating the ICU or the patient discharge from the hospital? Now, this is again the hierarchy of the parameters that you study. Don't think that you have a new drug and something for the first time, new parameter, new equipment, and you will talk about mortality or morbidity. So this is hierarchy. I think I could put in simple language. When you think of research outcome, you can think which parameters would be more suitable for this answering the research question.
I think beautifully described, the outcomes are important, but how you put them into your perspective is something you need to consider. In a setting which is a busy public hospital, even 1 day of lower ICU stay makes a lot of difference, because you are giving that bed to another patient who is waiting probably in A&E or probably waiting to get admitted. But in a private hospital, it may not be that different. At the same time, mortality will be something which is equivalent different, whether it's a public hospital, private hospital, or any part of the world. Yes, mortality do matter, and I think one of the more important hard outcome which makes a difference. But then you need to look at the softer outcomes, but look at your context. If you are taking those surrogate outcomes, whether they mean something for your setting, that need to be identified, rather than saying, yes, there is one. And I think, again, a composite outcome which you mentioned was something which we have recently seen big trials just to get that number power calculation started using composite outcomes. So what's your take on a composite outcome? Just for an example, we have a very large, beautifully done randomized controlled trial published in JAMA, and we know that Andromeda 2 shock trial. So it was a composite outcome. So what's your take? I think, take the last question on this. So what your take on that? Because it was not the mortality difference was because of, or the composite outcome was not because of the mortality difference, but because of the organ failure days. So how do you take the outcome of that study into the real context?
I think this is again important because, as we say, we're getting super specialized, and we have cardiosurgical ICUs and nephrology ICU. But finally, if you see the patient in the ICU, all organs talk to each other, and all organs are dependent on each other. If the heart does not function, kidney will go away. Kidney does not function, heart will go away. If lung does not function, there will be hypoxic injuries. So all organs are talking to each other. And when we say all organs are talking to each other, here comes the role that we have to develop something which continues the system working, the body system working, the body physiology. And here comes the role of composite parameters, composite outcomes. Recently, a group is working on a PPCs, a group is working on other models also. So when we talk about those parameters, we have to combine relevant aspects that will improve the overall outcome even for a system. For example, if we talk about a patient who comes after CPR, and we have the cardiac functions becomes okay, but he's neurologically brain dead. So if you are looking for a composite parameters, probably we have to look multiple parameters into this, which will, based on the research question, because based on the PICO that you have developed, will have implementation, or you can say clinical implementation, to bring some desired outcome change. So the composite outcomes are required definitely. But having said that, I will again say there's a hierarchy of things. So you cannot say that if you have developed some new technique, some new tool, or some new intervention, you cannot testify its significance first time in a pilot study based on composite outcome. So each intervention have some biological plausibility, some biological mechanism. First understands by one outcome parameter which is directly implicated, and then try to see for whatever purpose it is being developed, whether it is having an overall improvement in those composite outcomes. So this is, I think, what I can understand in a very broad platform. And this composite outcomes will probably depend upon intervention, the drugs, or whatever you are using it, and what are you looking for as a outcome parameter in those situations.
Thank you, Dr. Garg. I know half an hour is very, very short to talk about such an important topic, but you summarized it very well. I think you answered the questions, which are again very difficult one, especially talking about the spin and fragility index. You covered it, though there are so many other things to cover up. But just for the sake of the time, we will stop here. I will hand over back to Tapas to finalize the proceedings and a vote of thanks to everyone.
Thank you. I would say 2 hours of outstanding deliberations and discussions. So thank you everyone. And as we come to close of this landmark webinar for the first time related to research, I would like to thank each one of you for being part of something truly meaningful. And today's discussions have definitely reinforced something that evidence alone doesn't change our practice, rather our understanding about the condition, the patient, and finally we are here to treat the patients. Now, on behalf of NephroCritical Care Society, I extend my deepest gratitude to our distinguished speakers, Professor Bram and Professor Rakesh Garg, for sharing not just knowledge, but clarity and perspective how we should be having research that should be guiding our practice. And I also sincerely thank our esteemed chairpersons, Dr. K.R. Ramanathan. Somehow he is having on call right now, so he left little bit earlier, and Dr. Prasant Nasa for steering this session with insight and balance, and I would say academic depth that they have. Now this webinar marks more than just conclusion of an evening. We would be trying to also bring some of the the most important and path-breaking things that is in NephroCritical care. Till that time, some conclusion that I can make before winding up. As you return to your ICUs tomorrow, I hope you carry one simple message that I could understand from these 2 hours of discussion. Read the research carefully, question it respectful, and apply it responsibly. So thank you once again for your time, engagement, and your commitment for better academics. Thank you everyone, and hopefully you have enjoyed our session.